our next speaker. What we're going to do, I was told by Dr. Shamari, we're going to have a few minutes at the end of the session for questions and answers. So please write down your questions, and we'll have the speakers answer your questions. And we might take a couple minutes off the coffee break to do so. If you do have any further questions, we'll probably meet the speakers at the coffee break, and you could ask them separately. Our next speaker is Professor Levent. He comes from Turkey. I never met Professor Levent, but I was told, and I read his CV, extremely busy surgeons and a scientific person. He's going to talk to us about the aorto-iliac intervention. Professor Levent.
Thank you, dear Chairperson. I would like to thank the organizing committee and Dr. Al-Shamari for their kind invitation. It's a great pleasure to be here before you. I'm going to talk about aorto-iliac interventions. My disclosures. Well, when we talk about endovascular treatment of aorto-iliac interventions, we usually rival surgery, and we should know what surgery brings us. The patency for aorto-iliac obstructive disease in surgery is about 90% at 5 years and 80% at 10 years. These are primary patencies, so they are very high. Surgery is a very good method to solve the problem of aorto-iliac occlusive disease. However, it has high mortality and high complication rates. When we look to the task document, we will see that aortobiofemoral surgery has 90% 5-year patency as opposed to iliac PTA with provisional stenting, which has about 70% of patency. So what is the objectives of endovascular treatment? We should have high technical success to treat an aorto-iliac obstructive disease, should have low complications and high patency rates on short-term and long-term. We have stenosis, we have occlusions, and we have acute or subacute thrombosis on top of chronic lesions when we talk about aorto-iliac occlusions. And as methods of treatment, we have PTA, mostly with provisional stenting, direct stent placement, or PTA with provisional stent placement with self-expanding or balloon-expanding bare metal stents or covered stents, and as an adjunctive method, thrombectomy or thrombolysis when there is thrombus on top of those chronic lesions. So I would first talk about aorta and obstructions involving the aorta. Well, aorto-iliac occlusion or Leary syndrome is a subtype of task B classification, but itself is a distinct disease. Actually, it comprises about 3 to 8% of all aorto-iliac obstructions. It has a distal type in which the occlusion in the aorta extends up to the inferior mesenteric artery level, and a proximal type, where the occlusion is usually up in the renal artery level. And the vascular treatment in complete aorto-iliac occlusion has usually high technical failures and high complication rates because there is thrombus, and treatment of such lesions is usually hard. And there is rare literature reports on this subject. One of the largest one comprises only 20 patients, and that study reported that primary patency of endovascular treatment at 2 years of 66%, a very low account. When we look to the aortic stenosis, there are 2 different types actually. One is, on the left side, a localized form, whereas atherosclerosis is more common in male. Well, this type is more common in female. The typical clinical presentation for the localized aortic stenosis is a middle-aged woman who is a heavy smoker. The risk factors of atherosclerosis, such as diabetes and hypertension, is not very frequent in this subset of patients. And the diffuse form is what we see normally in atherosclerotic aortic disease. These are all both type B lesions with task classification. And the results in this subset of patients is encouraging because they are stenosis. Technical success is very high, approaching 100%, and the patency on long term are quite high. 75% primary patency at 5 years and 96% at, again, secondary patency at 5 years. When we look to the PTA and stent placement in this subset of patients, there were no big difference. But again, studies on localized disease of aorta or localized or diffuse stenosis of aorta are not very much. In our experience at Başkent University, we have treated 40 patients with aortic stenosis. 18 were aortic stenosis alone, and 22 was with contiguous iliac artery involvement. All except 2 patients had stenosis only. And we had a great success technically, moderate complications, and importantly, patency at 3 years was 100% for those who had aortic stenosis alone. Stents do a good job in aorta probably because the aorta is a very large artery and instant restenosis is not so much. When we talk about aorto-iliac obstructions, it's mostly iliac artery obstructions, stenosis or occlusions. So we will deal with iliac occlusions or obstructions after this. Well, since its introduction, we have treated endovascular way was started about the early 80s. So the world has been treating aorto-iliac occlusions or stenosis for about 30 years. And now we have good scientific evidence on that. We should have 5 years or 10 years patency rates to say something about PTA or stent placement. In this study, one of the earliest in the literature, the primary and secondary patency rates of PTA with provisional stenting or direct stent placement was 66% for primary patency at 5 years and 46% for primary patency at 10 years. So not bad numbers, but very low when you compare with the surgical treatment. Wow. The Dutch iliac stent trial was a randomized controlled trial. Randomization was made between PTA with selective stenting and direct stent placement, because one of the important issue here is whether we should do PTA with provisional stenting or we just do stent placement directly in aortic obstructions. Interestingly, PTA with provisional or selective stent placement had better clinical outcome in this subset of patients. However, ankle brachial indices, iliac patency, and score for quality of life between the two groups were very similar. And patency at a mean follow-up of 6.3 years was 74% for PTA with selective stenting and 83% for direct stent placement. When they collected data of all stents and all PTA alone, there were no difference. Well, this study from Abu Rahma showed that direct stent placement in aorto-iliac occlusions or obstructions actually reduced perioperative complications considerably, had higher clinical success for longer stenosis, that is task C and task D patient population, and similar clinical success on long term. Patency at 5 years was very similar for both PTA with provisional stent group or direct stent group, but in patients, because major complications were much more common in the PTA group. The major complication rate was 20% for PTA group and 5% with direct stent group. There were 9 episodes of distal embolization in the PTA group and 2 acute thrombosis, so they halted the trial. The trial showed that technical success in aorto-iliac obstructions and the vascular treatment of aortic obstruction was very high with direct stent placement, and the major complications was very low. COBES trial compared covered stents with bare metal stents. This is again a multi-center randomized controlled trial. There were more than 80 iliac artery segments in each group, and the longest follow-up for this study was 18 months. And this study showed that covered stents had less restenosis and less complete occlusions. And at the end, less reintervention was required for patients. On Kaplan-Meier analysis, life table, the patency of covered stents was higher when you compare with the bare metal stents. And this difference actually was more pronounced when we look to the task C or D patients, that is, extensive aorto-iliac occlusion patients. This is a kind of meta-analysis trying to show the results of endovascular treatment in patients who have task C and D aorto-iliac obstructions. Well, this study had shown that the technical success in this poor candidates actually was very high, with very high clinical improvement rates. 5-year patency was reached among 8 studies out of 19 studies, showed that the primary patency was between 60 to 86% at 5 years, and secondary patency was between 80 to 98%. So a very high rate of secondary patency, very comparable to surgical treatment. The most common complications seen in this collection of data was access site hematoma, distal embolization, arterial dissection, pseudoaneurysm, and iliac artery or aortic rupture. These are all common complications we face when we treat aorto-iliac obstructions with endovascular means. Our experience with chronic iliac artery occlusion is limited with 118 patients. This was our first experience in about 7 years. We used direct stent placement in all iliac artery occlusions. Technical success was at 92%. We had a high rate of complications, especially major complications. We have even seen one mortality, which is quite rare in this in endovascular treatment of aorto-iliac occlusions. Primary and secondary patency rates at 5 years were comparable to the literature. But from this study, we have learned that when you try to recanalize an occlusion, in an iliac artery occlusion from an antegrade road, your technical success is very high when you compare to retrograde road. When you use larger balloons to dilate the stents placed before, rupture risk is higher. And when you go retrograde, you can go subintimal into the aortic lumen, and when you place a stent in the subintimal aorta, rethrombosis rate is higher. And in the light of these data, we have collected our second group in the last 5 years. And this showed that our technical success increased from 92% to 99%, and our complications, especially major complications, decreased from 19% to 9%. So even after more than 100 patients, we had still a learning curve. There is one meta-analysis trying to compare the endovascular treatment and bypass surgery among patients who had aorto-iliac obstructive disease. And this meta-analysis had more than 5,000 patients, showed that endovascular treatment had significantly lower hospital stay, lower complication rates, and 30-day mortality. On the other hand, open bypass surgery had significantly higher primary and secondary patency rates at 5 years. But when we look to the numbers, endovascular treatment modality has quite low numbers in terms of primary patency, but when we look to the secondary patency with re-interventions, the ratio of patency is quite similar to the best surgical treatment. Well, restenosis is the problem. It can be alone, or there might be thrombus on top of restenosis. There are some risk factors. Which patients will have restenosis more? Occlusion length. As occlusion length increases, the risk of restenosis increases. If you increase the number of stents placed, again, the risk increases. If the artery is a small diameter artery, if the patient is younger or female, again, the risk of restenosis increases. If the presenting sign is critical limb ischemia as opposed to claudication, risk increases. Poor distal runoff, again, is a factor. And stent in the external iliac artery does worse than stents in the common iliac artery. What we do for restenosis of stents or PTA, again, PTA or direct stent placement. There are two large series. They are not very large, but large for this PTA or stent treatment for iliac artery in stent restenosis. We see the primary, well, when we have a recurrent disease, when a patient has a recurrent disease, then we have higher morbidity during intervention, lower clinical success, and lower 5 or 10 years patency rate. So when we compare with the index procedure, recurrences have shorter patencies. These two studies showed, one at the top showed a 66% primary patency at 10 years. On the other hand, the other study showed only 38% of patency at 5 years. So the numbers are differing greatly. In this small study, Dr. Chettis showed that in 14 patients, well, cutting balloon does excellent. But this is a small study to draw any big conclusions. The patency was 100% at a mean follow-up of 24 months for in-stent restenosis. In the light of this literature, direct stenting was reported to reduce risk of rupture, reduce distal embolism, reduce oral complication rates, and has higher short-term patency when compared to PTA with provisional stenting. On the other hand, PTA with provisional stenting, although had low short-term patency, had similar patency when we compare with direct stent placement on long term. PTA with provisional stenting has little higher complication rates, but there is only one thing. In most of these patients, nothing is left behind the iliac arteries. And direct stent placement was recommended for aorto-iliac junction occlusion or stenosis because there are tight stenosis there, and when there is heavy calcification in the iliac arteries, and in case of iliac occlusions. As conclusion, endovascular treatment of aorto-iliac disease has high rate of technical success, low morbidity and low mortality, but success has been limited by technical failures, mostly seen with occlusions, acute stent thrombosis, and restenosis on short or long term. Stents, and especially covered stents, did better than PTA with provisional stenting, but we need more data and we need more techniques, maybe drug-eluting stents or drug-eluting balloons in the iliacs to have a similar patency with surgery. Thank you very much.